Okay, hi everyone. Welcome to this episode of the REFERROLOGY series where we have Dr. Andre Tan, an endocrinologist, who will be discussing with us about the topic of osteoporosis. So let's dive into the first question. Dr. Andre, so which patients should we be actively screening for osteoporosis?
Okay, I think it's good to start off with the understanding of the progress of bone over a person's lifetime. So I mean, I put in this diagram showing the trend of bone mass over a lifetime.
Yep.
The line at the bottom shows the one for a woman, and then the one above is for a man. So
Okay.
you can see that actually in the left side of the graph, towards the early to mid 20s is when we start to build up bone mass, and we reach a peak bone mass somewhere in the 20s. And thereafter, it sort of plateaus off. And for women, unfortunately, due to menopause, they actually start to have rapid bone loss around the perimenopausal period. So that's when they actually start to be at risk for bone deterioration and fragility. And that puts them in the osteoporotic range.
Okay.
Whereas for men, it is actually, they only start to have to enter the range of osteoporosis more like in the late 60s to 70s. So I think if we talk about the question of screening, maybe
Yep.
if we talk about the question of screening, really it's, if you think back about the criteria that we have for screening tests, I mean, we definitely want to pick up patients in the early phase of disease when they don't demonstrate obvious symptoms. And if we can intervene early and prevent adverse outcomes, that would be good. And also if we have a good test that is readily available, is cheap, is accurate, and that all actually is readily available in osteoporosis testing. In that, in the early phase, of course, patients don't develop symptoms until they have a fracture. So by picking up patients that are at higher risk and putting them through a DEXA bone scan, we can actually pick up the patients where they already start to have significant osteoporosis. So some of these risk factors that we are looking at, of course, for in terms of the physiology, age is one of the main things. So the woman who is has undergone menopause and is postmenopausal, and the man who is 65 years or older, we would want to screen these patients. And then this is the additional list from the appropriate care guide that lists some risk factors that you want to look out for to screen patients for osteoporosis. So obviously, like things, lifestyle factors like smoking, excess alcohol intake, lack of physical activity or poor diet would put them at increased risk. And then of course, disease factors like rheumatoid arthritis, diseases that require steroid treatment, and so on, early menopause, or certain endocrine disorders like hyperparathyroidism will also put them at increased risk for early bone loss. And so these patients should be screened earlier.
Okay.
And then also in postmenopausal women, there's this easy tool called the osteoporosis screening tool for Asians, and that can be used in like the primary care setting or even in hospital setting to quickly check if a patient may be at increased risk for osteoporosis. So that is the next slide.
Okay.
Will put them in either the low risk, medium risk, or high risk category. And this is quite intuitive in that when you look at it, obviously a patient who is very old, who is very small size, i.e. the weight is much lower than the age, would be a high risk patient, whereas someone who is relatively younger with a higher would be a lower risk patient.
Okay, sure. And sorry. Okay. Maybe before we move on to the next question, I wanted to ask two questions. The first is in patients, let's say, who are taking steroids, because steroids is a big risk factor for osteoporosis. What would be considered significant steroid use that would require screening for osteoporosis?
Okay, that's a good question. I think the studies have actually shown that, of course, any steroid compared to no steroids will already increase the risk for osteoporosis, and the risk obviously increases with the dose, cumulative dose of glucocorticoids taken and the duration that they take it. Usually, we sort of give a ballpark cutoff of like 7.5 milligrams daily or higher over a 3-month period or longer to
Okay.
start thinking about screening for glucocorticoid-induced osteoporosis.
Okay. And when we mean screening, do we mean that we immediately bring these patients in for a BMD, or do we then apply the FRAX score to them and then that becomes the screening tool?
We generally do the DEXA scan, the BMD
Okay.
scan for them to
Okay.
evaluate. Actually, the compared to postmenopausal osteoporosis, where maybe over a year you expect 1 to 2% drop in the bone mineral density,
Yep.
when patients are taking high dose glucocorticoids, they actually have much more rapid bone loss in the first like 3 to 6 months already. So
Okay.
your bone mineral density may actually lag behind in terms of being able to tell you if the patient is losing significant bone mass. So actually, if even in these patients, without waiting for a bone mineral density scan, we want to consider starting them on treatment early. Yeah.
Okay, sure, got it. Okay. So this case scenario, we'll just use it to roughly, very loosely tie around the subsequent questions lah. So this is a postmenopausal woman with background CKD3 who presents with a fall after she slipped in the bathroom and landed on her buttocks and is complaining of some lower back pain, with the X-rays showing new L4, L5 compression fractures. So the first question is, how do we diagnose osteoporosis in general? And I guess alluding to that case also, because sometimes people say, when there's a compression fracture, it may affect the way the BMD is being read. So when do we do the BMD for such patients?
Okay. Obviously, the defining feature of bone fragility is that of a fragility fracture.
Mm.
And catch the patient before they even develop the first fracture. But if let's say you have a patient who has a fracture from a low energy injury, i.e. Falling from a standing height or less impact, and then the fracture affects the classic sites like the hip, pelvis, vertebrae, proximal humerus, and so on. These are classic fragility fractures. I think there's some contention about the distal radius fracture and whether or not it really always counts as a fragility fracture, because sometimes the impact can be fairly high, and if the entire body weight is just placed on one outstretched hand, that might, even in a young person, be sufficient to cause a fracture. So,
Okay.
but a lot of times in these patients, we already screen them for osteoporosis and consider treatment if they are presented with distal radius ulnar fracture.
Okay.
The fingers and toes, I mean, the architecture-wise of the bone is a bit different, and so is the skull. So fractures in these areas may not always count as a fragility fracture.
Okay.
And I think it's important to also take into consideration the progression of disease over time, in that in the early phase of osteoporosis usually affects more trabecular bone. So the vertebral column is affected more in the early part of the disease. And later on, then the cortical bone is affected more. So the hip comes in later. And so patients usually get more vertebral fractures first. And then it's only in the 70s and later that they start getting hip fractures. Yeah,
Okay.
and a lot of the vertebral fractures sometimes are subclinical or asymptomatic, and may only be picked up when we notice that the patients are getting more kyphotic, or there's
Yep.
a reduction in height.
Okay. So once they have a fragility fracture, regardless of the BMD, they'll be considered osteoporotic?
Yeah, that
Okay.
is a diagnostic criteria
Yep.
for osteoporosis already. Yeah.
Okay. What about patients without fragility fractures?
Yeah, so if you look at a bone mineral density scan report, there'll be a lot of things going on, and a lot of people just focus on the T-score,
Yep.
maybe not really understanding the whole report. So I think it's important to look at all the individual components and understand the interpretation of it. So you obviously have to look at the picture of the area of interest being taken. And in this case, it's the left hip. And sometimes it's the right hip if the left hip has a fracture or some kind of implant. But generally, we use the left. And for the left hip, we have two regions of interest, which is firstly the neck of femur,
Yep.
and as well as the total hip. So you can see the table below. There are a few numbers, and actually it
Yep.
tells you that there's for the left neck of femur, what is the area in cm squared, and then the bone mineral content in grams, and then they divide the bone mineral content over area to give you the density.
Yep.
And then there are two scores, the T-score and then the Z-score. So the T-score really compares that bone mineral density to that of a young woman of between 20 to 29, and tells us whether, I mean, we based on the T-score, we judge the score to be either in the normal range or osteopenic range or osteoporotic range.
Okay.
And then there is the Z-score, which actually compares that bone mineral density against the same age and gender that the patient is in. So it compares against the same group that in the population where the patient belongs to. So it's more like your comparing against your the mean for your age and gender, and how far are you away from that mean. So the Z-score is actually how many standard deviations away from the mean. And if it's -2 and below means you're further like more than 2 standard deviations away from the mean, which means that you fall in the like a less than 2.5 percentile or above the 97.5 percentile for that population. So it's quite nicely depicted in the picture on the top, where you see the green, yellow, and the red, and then the 3 lines. So a bit like your growth chart, except this is at the other end of your life. This is the bone actually declining with age. And the middle, I mean, for the 3 lines, the upper line shows the Z-score of +2. The center line is the mean, and then the bottom line is the Z-score of -2. So as you can see, that actually it starts to slowly decline around the 45 to 50 kind of age. Whereas the green, yellow, and red is actually the T-score of -1 and above, and between -1 to -2.5, and then -2.5 and below. And then this particular bone mineral density scan belongs to a 42-year-old woman who is premenopausal. So you can see that there's a little dot there where it shows where her neck of femur bone mineral density is, and it's actually lying below the Z-score of -2. So she's actually out of the 95% of age and gender, which is a region where we want to think about whether there's any secondary cause leading to a bone mineral density that's out of the usual reference interval.
Understand.
Yeah.
So the Z-score is helpful in terms of pointing for possible secondary causes. Is that correct?
Yes, that's right. So if you have a patient whose Z-score is below -2, then you probably want to keep an eye out or screen more actively for secondary causes. And we use the Z-score in premenopausal women or younger men.
Yep.
Whereas if you're looking at postmenopausal osteoporosis, then we use T-score. Because obviously in a woman who's after menopause, everyone in her age group will have a declining bone density. And if you judge her against someone else of the same age group, maybe her bone density is okay for that age group, but it doesn't mean that she's not at increased risk for fracture, because she's already progressing into like maybe osteopenia or osteoporosis.
Okay, got it. Thanks.
Yeah, I think the next picture is just for the lumbar spine. Similarly, we look at the T-score and the Z-score. So the lumbar spine, they take the first 4 lumbar vertebrae, like L1 to L4. And then they combine it as a total. So actually, when you look at bone mineral density reports, there are 3 regions of interest: the neck of femur, the total hip, and as well as the spine. And then, of course, there are all these caveats with regard to interpreting bone mineral density reports. Particularly at the spine, you want to watch out for whether there are obvious osteophytes and all at the intervertebral regions, where that can actually influence the measurement of bone mineral density and make it look falsely elevated. It might be difficult to also pick up, but patients with aortic calcifications, because the aorta overlies the vertebra, it can also increase the density on the DEXA scan. Only with a lateral X-ray film, then you can actually see the vertebral calcifications. So sometimes, if just a BMD alone, you might not be able to know if this is a factor that's affecting your interpretation. And then for the hip, then you look at whether there are whether there's sclerosis around the hip, like OA changes, which can also cause a false elevation of your results.
Understand. Okay. So you mentioned that there are 3 regions. Do the 3 regions weigh equally in terms of our diagnostic assessment of osteoporosis? Or does, like, one, so long there is osteoporosis in one of the levels, then it's counted as osteoporosis?
Yeah, very good question. So yes, when we look at all three regions, we take the one that is the worst. So
Okay.
if let's say it's osteopenia in the hip, but then osteoporotic in the spine, then we say this patient has osteoporosis.
Okay. And when we
Yeah.
follow up patients also, do we tend to use all the values, or do we tend to follow one more closely?
I look at all three values because, like I said, it depends on the stage of the disease that you are in, and if it's earlier on, the spine is likely to be worse compared to the
Okay.
hip. And there may be other factors that influence your interpretation of one area or the other. Like if the spine has a lot of fractures already, then you can't look at the spine and you have to follow the hip. Or
Okay.
if the hip has some problem, like there's a hip replacement already, then you can't really
Mm.
follow the hip over time. You have to look at the spine. So those are
Okay.
the things.
So back to our lady who fell and she's admitted currently, would you get the BMD done inpatient or should it be done outpatient?
Ideally, of course, if you can do it inpatient, that would be good to have
Okay.
a baseline of how her bone mineral density is.
Mm.
But I think in practical sense, that's not always possible.
Mm.
It's not always possible to get a bone mineral density done inpatient. And whether or not the bone mineral density is required for initiation of therapy, also no, because if there is a
Mm.
fragility fracture, obviously she is already osteoporotic and she fulfills the criteria for initiating treatment. So
I see.
we shouldn't wait for the bone mineral density to start treatment.
Okay. Yep. I think you wanted to also tell us a bit about the role for the FRAX score. So how do
Yeah.
we use it in clinical practice?
Mm-hmm. Okay, so the utility of the FRAX calculator is sort of to risk stratify the patients in the osteopenic range, because when the patient is in the osteoporotic range for T-score, obviously then they already fulfill treatment criteria. But
Mm.
there's going to be a lot of patients who fall in the osteopenic range that you maybe some of them actually are at a higher risk for fracture compared to others. So how do we pick up those patients and initiate them on therapy early rather than wait for the fracture to happen?
Okay.
It is the utility of FRAX. So the FRAX on top of the T-score actually incorporates all other risk factors, for example, the
Mm.
body mass, presence of previous fracture, secondary causes, and so on, to
Okay.
give you a more accurate representation of the 10-year probability of fracture. And for now, we use a cutoff of more than 20% for major osteoporotic fracture and more than 3% for hip fracture as sort of like the high risk cutoff and for initiating treatment for these patients.
Okay.
But I think in the years to come, there might be amendment of the guidelines to have a more like age-specific cutoffs. So maybe
Mm.
younger patients, we want to start treatment at lower risk cutoffs compared to
Okay.
older patients and so on. So the FRAX can be done without the BMD score. So you can actually key in all the risk factors and not key in the femoral neck BMD. And it will also give you a risk. So you can actually do it in the ward without doing a bone mineral density.
Okay.
In a patient that has not been diagnosed with osteoporosis before, has no fractures, but you just want to sort of figure out if you should screen the patient. Number one, you can use OSTA if it's a postmenopausal woman. If
Yep.
the OSTA is already high risk, then you put it into the FRAX, it will also be high risk. So if your OSTA is already high risk, you may not need to do the FRAX. But if let's say it doesn't, the OSTA is not high risk, you can use the FRAX to sort of give you an idea of the risk involved.
Okay. Got it.
Hmm.
Thank you. Okay, so the next question is about secondary etiologies. When do we need to look for them? So I think you alluded to in patients where the Z score is significantly compromised. And are there any other instances? And what do we normally do in terms of secondary workup?
Okay, so this is like a sort of a list of investigations that I generally do for first visit patients in the clinic when I evaluate them for osteoporosis. From health economics point of view, you don't need to subject all patients to secondary workup because the postmenopausal osteoporosis is still going to be the most common cause if you're
Mm.
faced with a woman who's like in her 50s, 60s or
Yep.
older. And a lot of these tests would return normal results and be quite redundant. But I think from a long-term follow-up point of view, I feel it's more comfortable for me to make sure that I have excluded all possible secondary causes, especially the more common ones at the start,
Okay.
so that when I follow them up or let's say discharge them to primary care, then we won't be worrying about, let's say, a secondary cause coming up later on. Because there are patients whereby they've been treated for many years and they're not getting better, and then we find out actually there was an underlying secondary cause that aggravated the bone loss. So I guess it's more of trying to make sure these things are ruled out at the start. And actually, things like vitamin D deficiency, insufficiency is very common in our population. So it's really quite a common thing to check for in these patients. There are some other points when if you click the slide. So yeah, that's what I was saying. So actually, they don't predominantly all of them would have quite normal results. Yeah, then in the middle-aged woman, primary hyperparathyroidism is also fairly common. So we have picked up a few cases on screening when they have hypercalcemia, then we go on and work up the hypercalcemia and find that they have hyperparathyroidism also. So other things that you, other situations where you consider doing secondary workup or repeating a whole set of evaluation would be, let's say you are treating the patient, but despite good adherence to treatment, the patient has treatment failure. I think we'll touch on this later. Let's say the bone mineral density is worsening or there are new fractures occurring. Then you want to go back and reevaluate to see if there's some other cause other than the normal pathophysiology of postmenopausal osteoporosis going on, causing further bone loss.
Okay, understand.
And, so the young patient and the patient with Z score of less than -2 and the treatment failure cases.
Got it. Okay, thank you. So the next question is about timing for treatment initiation. So number one, following a fracture, should we be starting immediately or should we wait for healing? And do we need to get some of the things, some of the groundwork done? I think the subsequent questions would touch on that, things like dental clearance, optimization of VT and calcium. Yep.
Okay. Yeah, I think your question pertains very much to the one aspect is whether or not anti-resorptive therapies and all that affect fracture healing if the patient has just sustained a fracture, and also the what preparatory work you need to do before starting a patient on some of the bone active agents in osteoporosis therapy. And this is in tension with the fact that, of course, after an index fracture, the patient is at much higher risk in the first year to 2 years of developing more fractures. So you want to start treatment early, and if let's say they are admitted for management of the post-fracture sequelae, then that's actually the most optimal time to advise them on treatment and initiate them, because when you discharge from hospital, they may get lost to follow up, or the emphasis on treatment may gradually wane with time, and they don't feel it's so important for them to start treatment. So I think in terms of fracture healing, like anti-resorptive agents, I think meta-analysis have shown that there isn't any significant effect in delaying fracture healing if you start the patient on like bisphosphonates early on after a fracture. But let's say if there is fixation and implants put in, some surgeons may have their concerns about whether the anti-resorptives may affect the growth of bone around the implant and the uptake of having the healing around the implant. So it would be good to discuss with the surgeon to find out if they're comfortable with starting the bisphosphonate or anti-resorptive therapy after that.
Okay, sure. Yep.
Yeah, and then this slide is basically to show that actually most of the agents that we utilize in treatment of osteoporosis are actually beneficial in terms of reducing both vertebral and hip fractures.
Okay.
If you could click, and then so the fracture risk reduction is a lot more for vertebral fractures, but I mean you can roughly quote a 30 to 50% risk reduction for fractures across the board if they are on any form of these medical therapy agents.
Okay, thanks. Okay, so the next question about the how and whether we must do this before we start treatment in terms of optimizing calcium and vitamin D status.
Yeah, I think again back to the physiology, it's important to appreciate that bone is a major reservoir for calcium in the body, and a major player in calcium homeostasis. So a patient who has very poor calcium intake and also vitamin D deficiency or insufficiency there's very little calcium absorption from the gut. And the patient is in like a state of calcium deficit. So where the calcium is going to come from is actually from the bone. So patients with this kind of dietary issues and vitamin D deficiency will be having more accelerated bone resorption and bone loss over time. So as far as possible, we want to correct for that. While just giving calcium and vitamin D alone is not adequate treatment for osteoporosis, in most cases they are actually insufficient in these aspects. So it's important to actually educate them about what are calcium-rich foods in the diet that they can take, and we try to focus more on dietary sources rather than supplements. So if they really cannot take a diet that's fairly rich in calcium, then we add on supplements to sort of top up so that they can achieve the daily requirements, which is actually 1,000 to 1,200 milligrams of elemental calcium a day for someone who's 50 years and above. And it's actually not that easy to achieve that, especially if, let's say, you have lactose intolerance or you don't really like to take soy products. Vegetables and all that actually don't really have that much calcium now. And the usual calcium add vitamin D that we give, like 2 tablets, actually is about 360 milligrams of elemental calcium per day for 2 tablets. So still, it's also only about a third of your daily requirements. So really need to try and get more dietary intake.
Okay, so for patients who really like don't eat any of these dairies and things like that, then how you mentioned it's only about 360, about 1/3. So do you have alternatives in terms of supplemental calcium, and what do you normally give?
Yeah, obviously, if they can't achieve a good dietary intake of calcium, then we want to give them a supplement that has higher amount of elemental calcium. So if you use a calcium carbonate, you have to appreciate that only about 40% of the mass of the calcium carbonate is elemental calcium.
Okay.
So if you want to give higher elemental calcium, then I will use like 1,250 milligrams of calcium carbonate, which goes out to about 500 milligrams of elemental calcium.
Okay.
Or the caltrate 600, actually 600 is the elemental calcium. So that has actually 600 milligrams of elemental calcium. So that's actually achieving 50 to 60% of what you require in a day, which is a lot better than like 30% of that. Yeah.
Okay, got it. And in terms of vitamin D supplementation, how do we go about replacing the vitamin D?
Okay. Yeah, I think there's a lot of different opinions about where we want to reach in terms of vitamin D, in terms of long-term follow-up as well as in terms of before we start treatment. I think in the majority of our patients, we see vitamin D levels at the start where they are less than 20, like 14, 17, or even less than 10. So those are patients where you really want to give them a bit of higher dose loading dose of cholecalciferol, 25,000 units a week, to try and bring it up to at least above 20. Of course, if you can reach 30 and above, that would be the most optimal. Then after that, the maintenance is more like 1,000 units a day cholecalciferol for long term. If the question is, do we top up the vitamin D before we start treatment? For oral bisphosphonates, maybe we don't really need to reach like above 20 or 30, but they may have more musculoskeletal side effects if they are vitamin D deficient. So ideally, you want to have the vitamin D above 15 to 20. But you can actually start them on loading, and then maybe after concurrently you can take the bisphosphonates, or after a week to 2 weeks of loading, the vitamin D level would have come up sufficiently that they can start the bisphosphonate without significant side effects. Whereas for the more potent anti-resorptives like zoledronic acid and denosumab, you want to make sure that the vitamin D is a little bit more decent, nearer to 30. Because again, if we think back about vitamin D deficiency and the patient being in a deficit of calcium, they're really dependent on the bone releasing calcium into the blood, the resorption of bone. And if you give them a very potent anti-resorptive and block the resorption of bone, then you're going to get a high risk of hypocalcemia, because the release of calcium into the blood is blocked, and they're not getting enough in their diet. So you want to make sure that these factors are optimized first before giving them the drug.
Understand.
Otherwise, they will have side effects and they will never want to be on the drug again.
And what about if you choose an anabolic agent upfront? Do you need to ensure that the vitamin D is replete?
Probably not a essential prerequisite to
Okay.
do it before we start the treatment. But I think obviously as part of the general
Yep.
management, you need to optimize these things as well, this factor as well.
Sure. Thank you.
Yeah, and whether to recheck or not, usually I would recheck before giving denosumab or zoledronate to make sure that the patient is too insufficient. But oral bisphosphonates wise, you don't have to keep rechecking. Yeah, maybe one follow-up is like once a year, we just monitor to make sure things are okay. Yeah, and I think apart from diet, of course, it's not mentioned in this set of slides, but activity is also a very important factor that we need to encourage exercise in these patients, particularly as they get older. There's also the factor of sarcopenia coming in and the increased risk for falls and all. So checking on their physical activity status and encouraging physical activity, like weight-bearing exercises, resistance exercises, and balance exercises are important.
Okay, yeah, thank you very much. Okay, the next question is about dental clearance. So sometimes in the wards, the consultants say, get dental to review before we can start. So what's your guidance on dental clearance and yeah, which patients need it? Do we need dentists to clear all the time?
Yeah, okay. I mean, I appreciate that we are not dentally trained, but the easiest thing to do is actually to look into the patient's mouth, right? And there will be a few conditions that are very obvious. One is the patient is edentulous, has no teeth.
Yeah.
Then you don't need to send the patient for dental clearance, otherwise it's quite embarrassing. Second thing is if the patient has very gouty, very bad dental condition, then obviously you want to make sure that the dental health is optimized before starting any anti-resorptive treatment. If not, later on they have to do extraction and all that, and it will complicate matters. But if patients are on regular dental review and they say a dentist tell them, oh, the dental health is fair and they don't need any imminent extractions, then it may not require another round of dental clearance before we start treatment. And also, depending on our choice of treatment agents, the oral agents usually have a low risk for osteonecrosis of the jaw compared to the more potent anti-resorptives like IV zoledronate and denosumab. And if you're looking at bone anabolic agents like teriparatide, then that's also not really a concern in that case. I think if you're thinking about osteonecrosis of the jaw, at the end of the day, it's a very, very low risk compared to the risk for osteoporotic fractures. And obviously the risk will gradually increase with more prolonged treatment. But we see osteonecrosis of the jaw a lot more in patients with oncology, with cancer, where they are receiving much higher doses of zoledronic acid or denosumab at a higher frequency. And there are also other factors like radiation and all that, which increase their risk. So yeah, I think we have to balance out the risk and benefit and explain to the patient quite clearly in that sense that it is a minor concern. But we want to make sure that patients who have already planned dental treatment go through those things before we start them on treatment.
Okay, so the concern from the dentist point of view is that if they're on the treatment and they go for dental procedure, then osteonecrosis of the jaw is higher risk complication. Is that correct? Or what is it that the dentist so that's the reason?
Yeah, that's right. That's right. So I think if any patient is already on bisphosphonate and they have a tooth extraction, I think the risk is like a 0.5% risk or 1% risk of getting osteonecrosis of the jaw. And it's usually with these invasive dental procedures where there's exposed bone, so like extraction, dental implants, or more invasive periodontal surgery. Yeah, so cleaning and scaling and polishing and like root canal actually are not associated with OMG.
Okay, thank you very much. That's helpful.
Yeah, this is like the appropriate care guide saying that, for oral bisphosphonates, it's a very rare side effect, and so actually you don't always need to obtain dental clearance before starting bisphosphonate treatment.
Okay, sure. Thank you. Okay, the next question is about the choice of the initial treatment. So we know we have the options of anti-resorptives, of which we have bisphosphonates, oral IV, and denosumab, and a range of anabolic agents as well. So maybe you could give us an overview of how you approach the choice of initial treatment.
Yeah, so you have rightly classified the two groups, large groups of treatment options into those that tackle the bone resorption and those that tackle bone formation. Because in a patient, a classic postmenopausal osteoporosis, there's increased bone turnover, i.e. there is bone formation, but the bone resorption actually outstrips the bone formation. So there's a lot more bone loss over time. So by blocking bone resorption, actually the bone mineral density will improve because bone formation will catch up. And then from a mechanistic point of view, obviously stimulating bone formation is a lot better than just blocking the resorption of existing bone. Particularly if, let's say, there is like a fixation or instrumentation, then you create new bone cells which will help to bind the implant better to the bone, and also the stimulation of bone growth would lower fracture risk a lot better compared to just blocking bone resorption. So these are the sort of categories, and then the ones that are actually in the grey text are agents that are still not available in Singapore. So basidoxifene is a SERM, selective estrogen receptor modulator, and then for the osteoanabolic agents, Romosozumab and Teriparatide are agents that increase bone formation, but are currently still not available here. Yeah. So yeah, I think I made this table to sort of summarize what are the kind of things that you consider when you talk to a patient about different agents. And I think later, for each particular one, we have our own elaboration on some of the considerations. Obviously, the mode of administration, how frequently they take it, and at your endpoint, if you're looking at how much fracture risk reduction you're achieving, then oral bisphosphonates, IV zoledronic acid, and denosumab are all good at reducing both hip and vertebral fractures. Teriparatide is more focused on reducing vertebral fractures and non-vertebral fractures. So non-vertebral fractures includes hip fractures, but if you look at hip fractures alone, teriparatide doesn't actually reduce that. And then if you look at raloxifene or basidoxifene, these are agents that only reduce vertebral fractures and have no impact on hip fractures. Then, so the other factors are like if the patient has reflux symptoms or prominent GI side effects, then oral agents may not be such an optimal choice. And then in terms of adherence, if you don't have to depend on the patient to remember to take a tablet or injection daily or weekly, then if you just give one dose every year or one dose every 6 months in the clinic, then that actually eliminates the issue of patients not taking their medications. Later I'll probably talk about it a little bit, but then in terms of like oral bisphosphonates and zoledronate, the trials have shown that their effects actually plateau off after a certain period of time, like 3 to 5 years. So beyond that, just continuing the agent may not give you a higher bone mineral density value, but it still helps to protect against fractures. And if you're looking at a very poor bone mineral density that you need to try to bring up a lot more, than denosumab has a positive effect beyond 5 years up to 10 years. So that is one of the considerations. The agents at the back, the denosumab, teriparatide, and all that, once they stop, the effects are lost immediately. So as compared to bisphosphonates, whereby the agent actually stays in the bone and has a residual effect even after stopping. So it's sort of like gives you that long-lasting effect for another year or two, and allows for a drug holiday as compared to the other agents. Then if there's a risk, if you're considering the risk for osteonecrosis of the jaw and atypical femoral fractures, then these have been reported with oral bisphosphonates, IV zoledronic acid, denosumab, even romosozumab as well. So, but in the short term, probably not that much of a concern when you're initiating therapy. Then raloxifene, you're worried about venous thromboembolic events. Renal function is an important consideration, because like in your patient who has CKD3, if let's say it's CKD3B and the creatinine clearance is below 35, then the bisphosphonates start to be a bit iffy, and you need to consider other things like denosumab, for example. And then of course cost is an issue that a lot of our patients face.
Okay, thanks so much for this summary table. I think it's a very useful perspective for us. Okay, so maybe we can talk about the individual agents at this point in time. So for bisphosphonates, so I understand in terms of oral we have alendronate and risendronate, and for IV it's zoledronic acid. So I guess number one, what's the dosing that we give? And because I understand for alendronate there's option of daily dosing as well as once a week dosing. So how do we decide between the two, and when do we give IV over oral?
Okay. If you look at the oral bisphosphonates first, I think the daily versus weekly is sort of equivalent.
Okay.
So I think from a adherence compliance point of view, once a week dosing is well tolerated, and a lot of patients are quite compliant to taking a once a week medication. The
Sure.
Resedronate also has a once a month preparation, 150 milligrams once every
Okay.
month. So some people may favor that, but then somehow I think remembering to take a medication once a month is not as easy as remembering to
Once a
take it
week.
every week.
Okay. Okay.
So yeah, correct. So that might be something that you have to discuss with your patient and figure out what is the best way to do it. The once a week medication, the oral bisphosphonates, you have to remember that the absorption is best in an acidic environment. So they have to take it on an empty stomach with no other interfering medications or food, and then wait for 30 minutes. And I think everyone will know that because of the risk for reflux or pill esophagitis, they need to drink a lot of water and allow the pill to go into the stomach and not lie down or go into a reclined position after taking the medication. And it cannot be crushed, so you can't give it through an NG tube.
Okay.
Yeah. And if patients with swallowing difficulty, also you cannot give oral bisphosphonates.
Sure.
Yeah.
Okay.
Yeah. And
Between
so
the
when,
once a week and once a day preparations, the GI side effects don't seem to be significantly different between the two, is it?
yeah, I don't. Yeah, they're not significantly different.
Yep.
Now there's a new alendronate which is buffered, so the pH is not as low, not so acidic. So that might be a consideration for patients where they experience GI side effects
Okay.
with the conventional alendronate, but the cost is a bit higher.
Sure.
And some people patients still have problems even with the buffered alendronate. So
Okay.
it's a consideration.
Yeah. And when does IV versus oral come into the picture?
Yeah, so a few situations whereby you consider giving IV would be, let's say if the patient has those issues that I mentioned before, like they have significant GI effects, or they have swallowing difficulty and you can't give them oral bisphosphonate.
Okay.
And a lot of times in the inpatient setting, it's quite easy to just give them one dose of IV bisphosphonate because the zoledronic acid actually lasts for a year to 18 months. I think there's a New England Journal study in like women above 70 where they gave zoledronic every 18 months, and actually it had very good effects in preventing fractures. So in the geriatric population, you catch them when they're in hospital, give them one dose, and then that actually protects them from fractures for the next 18 months. So even if they don't turn up again for follow-up, at least you know that there's some protective effect. And you don't depend on them having to take the tablet every week.
I see.
Yeah, but I think the IV bisphosphonate, the main downside is actually there's a very prominent acute phase reaction side effect after, and like for a few days to a week. About 30% of people may have the body aches, fever, flu-like symptoms and all that. So that's the major bugbear in terms of giving it, because a lot of patients don't tolerate it very well.
Okay.
Yeah.
And in terms of the cost profile wise, if you compare the once a year injection to, let's say, taking the oral bisphosphonates every day, does it equal out, or the IV is still more expensive?
Yeah, the IV is a lot more expensive.
Okay.
It works out to about $700 a year, whereas your oral alendronate is about $50 a year. And
Okay.
Resedronate
Okay.
is a bit more expensive, like it's about 200 to 250 a year.
I see.
Yeah, but the price differential is still quite significant.
Okay. Sure.
Yeah, and I think that what I forgot to mention is because of the acute phase reaction, a lot of times we pre-medicate the patient with paracetamol for the IV zoledronate, and then give them regular Paracet for one day to try and avoid the body aches and the fever, and then they can take PRN for the next few days to counteract those symptoms.
Okay, good. So it's something for us to preemptively let the patients know so that they don't get too surprised with this.
So if we do it in the ward, we can order the paracetamol. If we do it in, like say, OPIC, then we will usually order the pre-medication, the paracetamol one dose to be given before and so on.
I see.
And then prescribe the paracetamol.
Got it. Yeah. So you mentioned some of these earlier on. I think you covered most of it already, right? In terms of
I think that definitely I would not give oral bisphosphonates if they have documented esophagitis already or Barrett's esophagus, because then that is like a definite no-no. I don't want to aggravate those problems. And then patients with very mild symptoms, sometimes we just give them a try and say, it may not actually aggravate your symptoms, or they can try taking like proton pump inhibitors the night before. Obviously, they can't take it the same morning as the bisphosphonate because of the interactions and all that, but they can take it the night before, and sometimes that helps as well.
Okay, got it. Okay, so next we talk about Denosumab. So I'm guessing the main indication most of the time will be that of patients with renal impairment. Are there any other instances where Denosumab becomes your first go-to medication?
Okay, so the pros of Denosumab are like what I mentioned, in that it has a better effect in elevating bone mineral density over a longer period of time. So patients whereby the T-score is a lot worse, like negative 3 point something when they first start off, maybe they will respond better to Denosumab. And then compliance issues like a 6-monthly injection is easier to comply to compared to the oral medication. And then the renal function is also another factor. So if they have borderline renal function, creatinine clearance is 35 or less, then Denosumab is favored. In terms of the cost-wise, it is over a year is similar to IV zoledronic acid, in that it is about $700 a year.
Okay.
Yeah. So it's a 60 milligram dose given every 6 months, and we usually do it in the clinic. So they will come by, and then the nurse will administer it. And then there's the risk for hypocalcemia, which I mentioned earlier, especially in patients with renal dysfunction, with significant renal impairment, or those who are vitamin D insufficient or deficient. Actually, in terms of side effects, it's quite well tolerated. Very few patients have any significant issues after. There's like small risk of worsening eczema in patients with already existing skin issues. And in some patients, some clinicians prefer to give some calcitriol after the Denosumab injection to prevent the hypocalcemia. So they might give 0.25 micrograms for a daily for a week or 2 weeks after the Denosumab injection.
Okay, but that is not really standard practice.
Yeah, it's not a standard requirement.
Okay. And you did allude to earlier on that the effects of Denosumab wears off completely when it's stopped. So my understanding is that once Denosumab is started, it should sort of go on forever. Is that correct?
Well, in the sense that the patient shouldn't miss any injections. So the effect lasts for about 6 months, and after, let's say, if it's by month 7, 8, there's no repeat injection, then the bone starts to lose density and mass and all that. So it's actually quite a significant loss quite rapidly. So we should advise them that they need to have the regular injections every 6 months. And if, let's say, they plan to go off injections, usually we translate them to another agent, like a bisphosphonate, for example, to sort of sustain the effect. Yeah, but that might be a problem in patients with renal impairment where they cannot take a bisphosphonate. So they might have to be on it long term. Yeah.
Okay, understand. Okay, and for teriparatide, when do we consider anabolic agents upfront, and how do we go about giving it?
Yeah. Okay. The main barrier for teriparatide is obviously that the person has to inject the medication every day simultaneously, and the cost is also very significant, because it's I think it's about $700 a month now compared to $1,000, but I mean in a year it still works out to like $8,000 plus. The main benefit, of course, is that it builds new bone. So and its main effect is on reducing vertebral fractures. So it's mainly indicated in patients where they have multiple vertebral fractures to begin with. And in these patients, they are very, very high risk for developing more and more vertebral fractures, and that will cause them to have very severe kyphosis and all the problems come along with that. And the other kind of situation would be patients who are already on anti-resorptive agents but continue to have worsening bone density and continue to have fractures. Then the next step up would be to change it to an anabolic agent compared to an anti-resorptive agent.
I see.
Or patients who develop atypical femoral fractures or osteonecrosis of the jaw. So the anti-resorptives are not favored in those patients. So you switch to teriparatide, which has been shown in some studies to have increased healing of the atypical femoral fractures and the osteonecrosis of the jaw as well. So that's some of the instances where we think of that. Yeah, I think teriparatide, everyone will know that there's a sort of a cap of 2 years in a lifetime, because you can't you can't use it beyond 2 years cumulatively due to this theoretical risk for osteosarcoma, which was seen in rats when they studied the medication.
Okay. Do you, so you mentioned the two instances of one patients with multiple fractures and two patients who have sort of failed on anti-resorptives. What about patients who, let's say, hasn't had a fracture yet but has a bad BMD reading, let's say a T-score that is quite high, let's say less than negative 3.5. In these instances, do you tend to give it a trial of anti-resorptives and see how they respond first, or do you normally reach for an anabolic upfront given the very bad T-score?
I will put it out there as an option for the patient to consider, and some people may favor it because of the mechanistic point of view, like creating new bone rather than just blocking the resorption of existing bone.
Yeah. Okay. Thank you. And yeah, so when do the selective estrogen receptor modulators come in? Because when I look through most of the guidelines and stuff like that, it generally focuses on the bisphosphonates and then denosumab, and then anabolic. So where is the role for SERMs?
Yeah, so some sort of fill in this little nice window at the perimenopausal period, let's say like in the 50 to 60 age group.
Okay.
Where they start to lose vertebral bone mineral density first and increased risk for vertebral fractures. Because if you remember, the raloxifene and basidoxifene reduce the risk for vertebral fractures, but not other fractures. And also, I think the main problem with the SERMs are that they have like side effects like hot flushes, leg cramps, and also there's a risk for increased venous thromboembolism. So that might be a thing that you need to worry about when you put patients on these agents. But given that there are lots of concerns about long-term bisphosphonate use in a patient who's in the 50s, if you're thinking about the patient living to 80s, then the bisphosphonates might be a problem if you start off early in the 50s and you continue to have to give them bisphosphonates for many more years. So yeah, so probably in this age group of 50 to 60, there is a role for SERMs now.
Okay.
Yeah, balancing against the side effects, and also the cost is also is significant as well.
I see.
Because it's about 1,000 plus a year.
Okay. And for SERMs, is there a limited time which you can give it for, like some of the other agents, or
Usually, we wouldn't go beyond 60 because I mean, from a fracture risk point of view, you are going to be a lot more worried about hip fractures and non-vertebral fractures beyond 60.
Okay.
Yeah.
Sure. Understand.
So actually, also in the same line, if we talk about SERMs, we should also consider the menopausal hormonal therapy like estrogens and tibolone and all that. So these are considered for patients also in the perimenopausal period. Plus, if they have the significant menopausal symptoms, then gynecologists could give them hormonal therapy, and that will actually also help with the bone mineral density and help to reduce fracture risk.
Okay, understand. Thank you. And there's this new kid on the block, Romosozumab, that hasn't made its way to Singapore, but I understand that there's been some recent trials that show that it may be quite favorable in terms of its treatment profile. Do you have any comment on this?
Yeah. So Romosozumab is an osteoanabolic. It actually blocks sclerostin, which is an inhibitor of bone formation. So it actually, by blocking the inhibitor, it actually increases bone formation. And the bone formation in Romosozumab is actually a lot, is even more than that we see in Teriparatide. So there has been a lot of favorable data about the effects of Romosozumab in terms of increasing bone mass and reducing fractures with just 1 year of treatment. So I think this is something that is quite optimistic to look forward to if it comes around. But I think the cost will be a major issue.
Okay,
it does come around.
I see. So I think you've mentioned bits here and there. Maybe you can just give a quick recap lah. So based on my recollection, so for your oral bisphosphonates, it's the cheapest of the spectrum lah, right? So that would be about how much again for the alendronate and
50 each for alendronate and 200 each per year lah for risedronate.
And your IV bisphosphonates will go up to 1,000 plus, is it?
IV zoledronate and denosumab is actually quite similar. It's about $700 per year.
700 a year.
Yeah.
Okay. And for
Yeah.
teriparatide?
And teriparatide is it's about 700 per month, so it's like 8,000 plus in
I
a year.
see.
Yeah.
Okay, okay. And for teriparatide, it's not, there's no like subsidies and stuff like that for.
Yeah, currently it's not
Okay,
subsidized because it's a non-formulary medication.
understand.
Under
Okay.
the chronic disease management program, you know, I mean, the patients can use Medisave to pay for the consultation and some of the medication costs for osteoporosis lah. But then that
Okay.
pool of money is split between all the other chronic diseases
Yep.
as well, like diabetes and hypertension and all that.
Okay. Yeah. The next question is about assessment of treatment response. How frequently should we be doing the BMD, and what do we look at when we look at treatment response?
Yeah, in a general guide would be if you are initiating treatment, then you want to reassess a year later to check that the patient is responding well to the therapy. But in general, we probably if it's stable, we repeat every 2 years or so. I think that how we come up with these numbers is actually if let's say you're looking at postmenopausal osteoporosis, the decline in the bone density is 1 to 2% every year. Whereas
Okay.
if we trend bone mineral density because of like the error of the machine measurements, only a change of like more than 4 to 5% would be considered like a significant decrease or increase. So probably a 2-year interval is when you expect that if the patient had untreated disease, there will be a significant decline in the bone density. Whereas if the patient is on treatments and adequate treatment, then there shouldn't be any decline in the bone mineral density.
Okay, got it.
Yeah.
And what values
Yeah.
are we supposed to look at in terms of follow-up? Yeah.
Yeah. So again, if we look at the bone mineral density report, if this is not the first time the patient is doing the bone mineral density scan in this particular institution, then you will see that on the bottom table, there's this extra thing that comes out with the results history where it actually trends for you the bone mineral density done like a year ago and then this year. And then it tells you what is the change of the BMD versus the previous scan and also versus the baseline, the first ever scan that has been done.
Okay.
And it also gives you the percentage by taking the difference and dividing it by the original density value. So yeah, so in this case, there's very little change in the bone mineral density. It's just a change of 0.005 or 1% change at the neck of femur. So it's relatively stable.
Okay.
And right at the bottom of the report, if you it says significant at 95% confidence. LSC or least significant change is 0.029 grams per cm squared. So that's actually the margin of error. Let's say a change that is greater than that number would be a significant difference. Yeah, based on the machine characteristics and how they measure. So there's a margin of error, and anything bigger than that would be a significant change.
Okay.
If you click, that will be you can see the lumbar spine mineral density as well. And in this case, you can see that versus the previous scan, there is a 0.049 increase, 5.9% increase. So that's quite significant because the least significant change is 0.022. So 0.049 is quite a lot bigger than that. So over this 1 year, there has been an increase in the bone mineral density at the spine with treatment. And if you look at the picture of the spine, you can see that actually there are osteophytes between L3 and L4, which will influence your interpretation.
Is the darker areas here, is it?
Yeah, that's right. Darker areas.
Okay.
Yeah, so you compare against the previous scan and this scan, and they sort of look relatively similar, then probably that will cancel out. But if there's a difference in the appearance over time, sometimes they develop the compression fractures, but the technologist who's doing the scan forgets to, it doesn't go and exclude that particular segment. So it looks like everything goes, the bone density is a lot higher because when the vertebra gets compressed, then the area is smaller. So you have to look out for that when you look at the report.
Okay, understand. And if unfortunately your scan was done in another place, then you have to manually go and calculate the.
Yeah, that's right.
Okay.
And I mean, theoretically, if you have done it on a different machine, then you cannot directly compare the density, but you can sort of get a rough gauge of if it's a very significant difference compared to the previous reading.
Okay.
Yeah, and look at the image to make sure the positioning and all that is okay. Yeah.
Okay, got it. Ken, thanks. So this slide talks about,
Yeah, so
okay.
the expected response to like anti-resorptive treatments would be like usually in the first year with oral bisphosphonates, you see a slight rise in the bone mineral density, but usually thereafter it's sort of stable. Whereas if the patient was not receiving treatment, then obviously the bone density will decline over time. So you may not expect it to increase year on year in that sense, but as long as it remains roughly in that range, the same level as the baseline, then the patient is responding.
Okay.
And usually you see a better response at the lumbar spine because it's more trabecular bone, and that responds better to like anti-resorptive treatment.
Okay, got it.
Yeah.
Sorry.
So you shouldn't have any worse than 4 to 5% deterioration over 2 years. And I think
Okay.
we'll allude to that again when we talk about treatment failure.
Yep. Okay.
Yeah.
So this leads in lah. So so how do we define treatment failure, and what should we do in this context?
Yeah, so there are a few things that define treatment failure. Of course, clinically, if the patient has developed new fractures, then you have to consider this. And from a diagnostic point of view, looking at the BMD, if there's a significant decline in the bone density
Okay.
in one or more areas. And then sometimes we use bone turnover markers, but actually in practical sense, we hardly ever do bone turnover markers here to monitor response to treatment and all. Because we mainly look at the patient's clinical response plus the bone mineral density data.
Okay.
Yeah, if you click, then actually there's a criteria, but I think no one really needs to remember all these criteria. It's sort of like a tool or one or the other and so on.
Mm.
So the combination of the 3 factors that I mentioned above. But if the patient has more and more fractures as they are on treatment and you're quite sure that they are taking their medications properly or you're getting it, so there's no question of compliance, then you have to consider escalating treatment. So if you click again, then you'll see what are the options available. So if you're on a weaker anti-resorptive, you go on to a stronger anti-resorptive. So let's say if you're on oral bisphosphonate, you want to go to an IV zoledronic acid. Same thing for point 2, oral drug replaced by injectable drug. And then if it's already on a strong anti-resorptive, then you consider switching to anabolic agent. So like teriparatide, I've mentioned earlier, that's one of the situations where you consider switching to anabolic agents.
Okay. The effectiveness between IV bisphosphonate and denosumab is one superior to the other, or about the same?
Yeah, I think let's say if we consider the 2 different agents, denosumab will have a bigger impact on increasing bone mineral density in a sustained fashion over a longer period of time. Whereas for IV zoledronic acid, the studies show that after about 2 to 3 years, it sort of tapers, it sort of plateaus off and remains about the same. But the main pro of zoledronic acid is even if you don't give the drug, the effect is sort of sustained over a longer period of time. Whereas denosumab, you sort of have to keep dosing it every 6 months.
So if you're on IV zoledronic and then you meet treatment failure, can you switch to denosumab if the patient is compliant?
Yes, you can do that.
Okay,
Yeah.
sure. And what counts as a significant decline in BMD in terms of numbers?
So if the significant decline would be if you trend the BMD and you see that the change of BMD versus the previous is greater than your least significant change, the percentage change is more than 4 to 5%.
Okay, sure, got it. Thanks.
Yeah, because I think a lot of times people look at, oh, there's a 2% decrease and they think, oh, it's worsening, or they look at the T-score and they see the T-score is getting more and more negative. But sometimes it's actually not so much of a difference between the bone mineral density values. And sometimes the T-score changes depending on what kind of reference population you are comparing the bone mineral density against.
Understand. Okay. And we come to this bit, one of the last bits about transiting between agents, especially in the context of treatment failure. So I think because there are a few principles, things like, let's say, drug holidays, things like, let's say, limited duration, which you can give teriparatide, and I guess the questions of whether or not treatments should be overlapped. So let's say you're transiting from bisphosphonate to a teriparatide. Should the bisphosphonate still continue alongside the teriparatide? Yep. So how would you advise in this space?
I think we'll look at drug holidays first because that's probably the more most common issue that you might
Yep.
encounter when you treat somebody for osteoporosis. So the whole basis of how drug holidays work is that in the bisphosphonate trials, for oral bisphosphonate as well as IV zoledronic acid, they found that after a period of treatment, like 5 years in alendronate and 3 years in zoledronic acid, then they randomized people to continue receiving treatment versus placebo. And even in the placebo group, the bone density actually didn't drop to baseline. So they continue to have a sustained effect in maintaining bone mineral density with maybe just marginal increase in fracture risk during the time that they're on placebo. So that's why we think that, okay, even if you have treated them for a fair period of time, even if we take off the medication for a year, 2 years, or even a bit longer than that, the effect of fracture risk lowering would still be there. Whereas with the other agents like Denosumab, Teriparatide, all these agents, the effects will be lost immediately after stopping therapy. So that's why drug holidays only work with bisphosphonates, and we consider giving them a drug holiday. And also from the point of view of atypical femoral fractures, the longer that they are off treatment, the risk for these effects actually wear off quite drastically over time. Okay. So that it continues to benefit the patient, and the risk for fractures does not increase by a lot, but then you sort of reduce the risk for these long-term side effects.
Sure. And after how long do you consider a drug holiday, and how long do they holiday for?
Yeah, so the drug holiday is considered after about 5 years for oral bisphosphonates and 3 years for zoledronic acid, because that's when you sort of think, even if you continue to treat, the effect is sort of stagnant, you don't get a further increase in bone mineral density. And at that point in time, if you think the bone mineral density is still very poor and you want to get them to a better place than where they are now, then you should consider switching an agent rather than just continuing on the same treatment. So that's the decision time point, where it's either you switch to a stronger agent, or you give them a drug holiday if they've done quite well on that period of time.
Okay, understand. And we would reinitiate again only when we start seeing their BMD worsening. Is that correct?
Yeah. So if let's say I put a patient on drug holiday, I would monitor the bone mineral density 1 year later and so on. Yeah. Usually we expect the effect to the bone mineral density to be stable for a year to 2 years at least. And if let's say they start to decline thereafter, a significant drop in the bone mineral density, then I will discuss with them about restarting treatment.
Okay. Thanks. And the second question about transiting between agents. So let's say this patient's on bisphosphonates, and then you are going to start teriparatide. Would you continue the bisphosphonates for the consolidation effect, or is it okay just to switch to teriparatide and stop the bisphosphonates?
I think there's no guideline to say we should continue bisphosphonates while switching to teriparatide. I think there is unfortunately some data to show that starting a patient who is treatment naive on teriparatide versus someone who is already on bisphosphonate to switch to teriparatide, the effect is better, of course, in the treatment naive patient, because the teriparatide doesn't work so well when the bone turnover has been suppressed by the bisphosphonate already, and there's a sort of delay in terms of the onset. But that if we switch, we should just stop the oral bisphosphonate and continue with the teriparatide.
Okay.
So I think no guidelines right now really support like overlapping treatment or combined therapies.
And because for teriparatide you have your 2-year maximum duration, so what happens to them after that?
I think if you click through the next few slides, I think there is okay. Yeah, this one was just again back to the issue of the drug holiday, and that the Denosumab actually shouldn't be patients on Denosumab shouldn't be put on drug holiday. And then the appropriate care guide gives you a guide as to like when you consider drug holiday. Yeah.
Okay.
Then the next slide actually will talk about transiting off teriparatide or Denosumab. So if let's say the patient is on teriparatide and they're going to come off, then we shouldn't just leave them like that and then say, okay, never mind, there's nothing else thereafter. When we take off the teriparatide, they should start anti-resorptive, be it oral bisphosphonate or IV zoledronic acid or sub-Q Denosumab.
Okay.
And then for Denosumab also we switch to bisphosphonate. So I think a lot of the time these patients are referred to us to this sort of transition. I think a lot of the oncology patients, like patients with breast cancer who are on aromatase inhibitors, get denosumab to prevent bone loss, and then when they stop the aromatase inhibitors, then it's like, what do we do after that? Do we continue the denosumab, or do we switch them to oral bisphosphonate? And then we'll advise them accordingly about these issues. Yeah.
Okay. And if you're switching from denosumab to a bisphosphonate, then you would switch after 6 months from the last injection, correct?
Yeah. For oral, let's say if you're switching to oral alendronate, for example, so that like at the 6-month point from the last injection, then we'll start them on the oral.
Okay.
For IV zoledronic acid, it's a bit more complicated in that they show that there's better effect if we wait till about 8 months.
Okay.
So that's a bit different.
Okay, understand. Okay, so the last question about osteoporosis in CKD, because we also understand that patients in CKD also have other bone-related problems. So how do we navigate this space of patients?
It's a complicated question that cannot be easily answered in a few minutes. I think the issue of CKD, mineral bone disease, the impact of it will get bigger as the patient's CKD status gets worse. So obviously we're facing these problems in patients where their CKD stage is like 3B, 4, 5, and stage renal failure. And in these cases, we really need to be quite careful how we assess their bone status, because not all of them actually osteoporosis in the sense that there's increased bone turnover. And if they're already having low bone turnover and we give them an anti-resorptive which further reduces the bone turnover, then that's actually harmful for them. You can get adynamic bone disease, which is very severe. So that in patients with CKD, there's this TMV model where we look at the turnover, the mineralization, and the volume to try and figure out which area they fall in. And if let's say they have secondary hyperparathyroidism where there's increased bone turnover, then they will benefit from perhaps to actually reduce that bone turnover. So we collaborate with the renal physicians in assessing these patients and deciding what's best in terms of their bone management. I think in terms of like managing the phosphates, calcium balance, and suppressing the hyperparathyroidism, there's all these things that we need to consider as well.
I see. So these patients generally, if we see them, like let's say in our general medicine ward, it's probably helpful to get a specialist input rather than just assuming that compression fracture equals to osteoporosis and then just start anti-resorptives.
I think if you have CKD 4 to 5, definitely we should assess more carefully before treating. If it's let's say CKD 3, I would maybe send off the calcium phosphate PTH to see if there's any abnormalities. If they are quite stable, a lot of times their CKD 3 is because they are very old, their body mass very low, and therefore the EGFR the creatinine clearance is low. But actually their calcium phosphate, everything looks very pristine. PTH is okay. Then maybe we can still treat them as per our usual osteoporosis patients.
Okay, got it. Thank you. Okay, thanks so much, Dr. Andre. Maybe at this point in time, you could just share maybe some of the key take-home points that younger doctors and residents should take note of with regard to the management of osteoporosis.
Okay. I think if you see someone, a patient with osteoporosis, I think a few of the things to take note of is in terms of the management, it's not just all about pharmacology. That like any other chronic disease, it's really like there's a multidisciplinary approach in terms of your lifestyle management and all that, and addressing risk factors. And depending on where the patient is in terms of their life cycle and the disease status, then you might have to tailor your advice accordingly. And a lot of times our encounter with the patient in the inpatient setting or outpatient setting is a opportunity for us to actually give timely advice about these management points so that they actually have increased awareness about how they can manage the disease, not just from a drug perspective, but from other lifestyle interventions as well. And then of course in terms of the drug choices and all that, there are so many considerations when we look at what are the best options for the patient. So it's really an individualized approach when we talk to them.
Okay. Thanks so much, Dr. Andre. I think it's
Yeah,
been very
welcome.
helpful for myself, and I'm sure for the residents and doctors who'll be watching this video too. Thanks so much.
Thanks for me.
Okay, thank you.